think that's...
Yeah, no, it's fine. Arjun, we'll go to the next stop.
Okay.
Okay, thanks.
Brilliant. Thanks, Saurabh. So, guys, we're going to move now on to the trauma hand and wrist component of the course. And we're going to break this into two parts. So I'm going to talk to you more focusing on some of the decision making, and then Saurabh will take you a bit more in depth about the actual operative treatment and how you do it. Because the exam is made up of two parts. The 6 and 7 is the decision making, and then the 8 is really the details of the operation itself. Okay? So let's start with some common cases. And I'm going to try and do this in an interactive manner. Okay, so Miraz, this is a 24-year-old male, right-handed, who had a fight in A&E, fight 24 hours ago, has presented to A&E with a painful, stiff hand. Tell me what you see.
So I can see there's a clinical photograph of dorsal aspect of the hand, so focusing on MCP joint. I can't specify which fingers are they, but I can see there deep abrasions, probably puncture wound. I can see there is localized superficial necrosis or ulcerations. I think this is an open wound until proved otherwise.
Give me one phrase. What is this? You're the hand surgeon on call.
This is fight bite injury.
It's a fight by injury. So what are your concerns?
My concerns is wound communicating to the MCP joint.
Okay. What else?
With infection.
Okay, so you're worried about infection. What else are you worried about? With the place that it is.
So extensive tendon injury.
Okay. Which part specifically?
Which
Which zone, I should say?
MCP joint, so zone 5.
Yes, it's typically a zone 5 extensor tendon injury. And what structure normally gets injured in zone 5?
It can be either extensive tendons or it can be sagittal band.
Usually the sagittal band, which gets injured at this point. But yeah, you would check the extensor tendons as well. Good. So fight bite is a common complaint which they bring up in the exam. So typically it's a tooth mark at the site of the MCP joint, and it typically will take out the zone 5 extensor tendon or sagittal bands. So what would I do? Historically, I'd want to know about the chronicity since the injury. I'd want to know about what the nature of the injury was as well. Is their tetanus status up to date? And are they clinically unwell? Any history of immunocompromise? What's the classical bug which causes this? Typical bug, I should say. Typical bug, and then the classical one for the exam.
Typical will be staph and classical will be Echinella.
Yes, the typical is Staph aureus. The classical one they bring up in the exam is Echinella as well, corrodens. Okay, so your initial management should be about wound care in A&E. Okay, so tetanus, IV antibiotics, taking a history of immunocompromise, and then basically putting them in a Bradford sling for comfort, checking the neurovascular status, get an X-ray as well to make sure there's no fracture and also that there's no obvious foreign body such as a tooth, and checking the status of the tendons itself. So a very quick way that you can check if the extensor tendons are intact is by doing something called a tenodesis effect. Okay, so where if you passively extend the wrist, the fingers should flex. If you passively flex the wrist, the fingers should extend. Okay, so that's a quick way of me checking if the tendons are intact. Does this need to go in the middle of the night or not?
Yes.
Does everybody else agree with that? Oh yeah, so if it's a patient who's clinically well, they're not obviously septic or anything like that, then a fight bite injury could be treated with Bradford sling, IV antibiotics, observation overnight, and I'd probably take it first thing in the morning. Okay, obviously if they're systemically unwell, that's different, but this could potentially wait. In terms of your treatment, what position would you have the hand in? So you've got to wash this out. It needs an operation. Okay, there's no medical treatment for this. What position would you have the hand in when you're dissecting? So you'd have it in, so would you put the hand flat when you're dissecting, or what position would you put it in? Yes, the buzzword I want you to use for the exam is use a clenched fist position. You put it in the position that it was injured at the time of the injury, where the skin lines up with the tendon, lines up with the bone. The examiner will test that, okay? The next thing, Miraj, is you go down, you open up, you think that the capsule may be intact or not. Would you open the capsule if it's intact or not?
I would open.
That would be my personal opinion as well. I'd probably open the capsule as well. Would you do the same, Saurabh? Because my concern would be, could this be an in-out puncture wound? So you're never going to be criticized for opening the capsule. But if you leave it and they develop a septic joint, you may well be criticized. Okay, what will you do at the end of the procedure? Will you close the wound or not?
I would not close the wound. I would take the patient for the second look in 24 to
48 hours. Okay, great. So that's the fight bite case done, basically. Okay.
Good question.
Yeah.
What amount of radius where MCP when you're making a incisional capture, so you don't get like a kind of a drift of the tendons?
What would you do? Sorry, ulnar radial to the capsule.
You will give the answer. Did I show you any contour and proximal failings? Where you go on the tendon?
Right to the middle.
Right to the middle.
Exactly.
Tendon is taken care of.
Yeah.
Go through the same line. The capsule.
Yeah. Go for the same
Simple
thing.
line, simple. Keep it simple so that finally it will come out from.
For opening or not opening the joint,
Yeah.
can you do immediate test with saline?
I would just open it to be safe. For the exam, you're never going to be criticised. Okay. I always think in these, and I think of it in the exam, what gets you a basic pass or a 6? It's basically you being safe as a day one consultant. All right. And in terms of, I know this is a very negative way of thinking about things, but I always think what's going to end you up in a coroner's court? Okay, so always think of the question, what is going to get a complaint against me and that I cannot defend it? Now, I could always defend opening the capsule because I could say, my concern, it was an in and out injury. You will never be criticized for it. But if you miss that and then they pus out within 2 days and they potentially lose that joint because of septic arthritis, you will be criticized for that. Okay, so that would be my honest answer for the exam. Okay, next case, Sahil. This is a 35-year-old right-handed male, works as a carpenter, got a splinter stuck in his finger 5 days ago, and now presents with a 24-hour history of worsening pain and also is clinically unwell as well.
So this is a clinical photograph of the arm aspect of the right hand. There is a discoloration over the second level of the second MCVJ,
Yep.
As well as the discoloration of the tip of the middle ring.
Now, I think that's probably projectional, but basically, no, it's fine. The main thing is this area here, it's all red.
The index finger itself looks more swollen compared to the others.
Mm-hmm.
The creases are not as obvious. My concern that this is a flexor tendon sheath infection.
Right, so that's, guys, this is the thing which will get you struck off if you miss this, okay? So this is the thing you do not want to miss, all right? So, whereas I said the fight bite can potentially wait till the morning, if this person comes in at 2 in the morning eating a hamburger, what will you be doing?
So this is an orthopedic emergency.
Yeah.
I'll discuss this with our anaesthetic colleagues as to the risk of anaesthesia, and come to a sensible decision as to.
So this is rapid sequence induction. This is take it overnight. Okay, this is the one that you don't want to wait for. All right. So classically, how do we diagnose this?
This is a clinical diagnosis, including the history, examination. On examination, I'll be looking for canal signs,
okay.
Which is fusiform swelling, tenderness along the entirety of the flexor tendon sheath itself, redness, and pain on the movement of the digit.
So you got 3 of them, okay? So redness isn't one of them, okay? But for those guys listening, so Canaveral signs, that's the key thing you need to come out in the exam. So as you said, pain on passive extension, okay? Tenderness over the flexor sheath, fusiform swelling, and the last one is it has a flexed attitude, okay? So if you wanted to show higher order thinking in the exam, when you're given that, you could say, this is a clinical photograph which shows a fusiform swelling of the index finger with erythema down to just proximal to the A1 pulley. I note that it's a fusiform swelling. I cannot comment on whether there is a flexed attitude without looking at it. I also would like to test if there is pain on passive extension and also if there's tenderness over the flexor sheath. My concern is this is a flexor tenosynovitis. So what I've done is I basically named Canaveral signs without naming the word Canaveral. That's the higher order thinking. I'm showing that I understand that to the examiner. Yeah, those are little technique things that you can use, all right? So your initial management will be the same. History, find out about chronicity. Ideally, you want to get to these within about 6 hours if you can, okay? History of immunocompromise. I'd want to know if there's any obvious foreign body. On examination, I would check for Canaveral signs. I check if they're systemically unwell. I may do a radiograph as well to look for any obvious foreign body. I would start IV antibiotics. I would splint them in a Bradford sling and I would arrange for theatre. There's no medical treatment for this in a clinically fit patient, surgical treatment. What surgery would you do?
So in the currently consented marked anaesthetized and he checked his patient. I'll place the patient's spine with the arm table, and my incisions will be over the A1 pulley at the level of the MCP head, and a second incision at the distal interlocking joint at the crease itself, and I will go down to the flexor sheath in both positions and feed a cannula and perform a saline washout irrigation of the flexor.
So you've described doing a dual incision technique over the A1 and A5 pulley, washing with a cannula until the fluid is clear. Now in this picture here, the swelling is almost to the mid-palmar crease. Do you have any concerns with the technique that you described then?
So the concern is you could actually advance the infection or pass deeper into the mid-palmar space.
Okay, but also just in terms of treating the infection, sometimes if the infection has gone proximal to the A1 pulley, that technique may not work. So I would always try that technique first if I could, but what is your salvage? What can you do after that?
Yes, would you do a zigzag incision to...
What do we call that, a zigzag?
Brunner's.
Yeah, so you could do a Brunner's incision and flay the whole finger over it if you have to. You just have to wash this out. Right, so that will be the first part of your question, guys. And at the end of the procedure, you leave it open, come back in 24 to 48 hours for a second look. The second part, if you get onto that in the exam, and most candidates don't get that far, is they will say to you, okay, how does your management change if this is a thumb or a little finger?
So because of how the tendon sheaths connect, there's a connection between the thumb and the finger, and you get horseshoe access. So
What do we call that connection between the thumb and the little finger? Where do they connect?
So it's not on space, because of middle on space.
So it's just proximal to the carpal tunnel. There's a space called the space of Parona. Have you guys heard of that? P-A-R-O-N-A. Okay, so always check for tenderness there. Now, I have seen them in the recent exam. They actually gave a patient with an index finger, and they said, it's got onto the little finger. What do you think's happened there? This is one that they brought in the recent exam. Does anybody know?
In around 10-20% of the population, you can have an abdominal collection.
Exactly. So it's an anatomical variation where you can actually get communication between the index finger and the first or the fifth, or even the middle finger and the first or fifth. Just be aware, this question is normally divided into two parts. The first part being flexor sheath infection, the second part being palmar spaces of the hand. Okay, so that's what you've got to be thinking of, your higher order thinking in this question. Okay, just a 30-year-old chef who fell from a standing height. Tell me what you think of these radiographs.
Yeah, the AP and lateral radiograph of wrist plus complete mesh rotation, and looking at the X-ray of the AP view, see a distal radius structure with the shortening of the radius, and the radial height is shortened, and inclination, radial inclination of, I would say is acceptable. And on the lateral view, there's not much dorsal stitching, but there is some evidence of angular translation or possibility of oval bottom type. So we need to get the history and proper history.
Do you think it's molar bottom type?
I mean, there is potential because it's shortened and then slightly angulated.
Okay.
And there's a dorsal comminution as well.
Okay.
And
well, let's imagine that it's treated conservatively. I was going to say I think you're quite harsh taskmaster. That's good. I like it. Okay. So let's say this was treated conservatively.
Yes.
If it's a distal radius fracture undisplaced, you bring the patient back in 6 weeks' time.
Yes.
What's your concern when anybody who has a distal radius fracture treated conservatively? What would you want to check when you see them in the clinic?
So, I mean, body-wise, I would want to make sure that radiography.
Body-wise is fine. What else would you check?
So, we want to make sure that the patient has any pure ruptures.
Excellent.
Pure
Yeah.
ruptures.
So the patient comes back to see you in the clinic. Tell me what you see here.
So it's a clinical radiograph of left hand dorsal aspect. and on the thumb, I could see an attitude of flex IPJ. And but ideally, I should check the retropulsion.
Yeah. So how would you check retropulsion?
So I was asked the patient to put the hand flat on the table.
Yeah.
And asked to lift the thumb to the ceiling.
Yeah.
And I could, that is non-palpable, but I should palpate, see whether there's any tightness of the EPL all the way from the thumb to the wrist, and see whether there's any tenderness and also sometimes there's an rupture that would.
So how would you treat this?
So
there's an EPL rupture.
Yeah, so EPL ruptures, I mean, depending on the patient, if the patient is young patient, acute, in the acute stage, I should not, if it's clinically possible, then there's no point doing ultrasound scan.
Yeah. No waffle. How are you going to treat it? One word, one phrase.
Tendon reconstruction with the EIP to EPL transfer.
Very good. So tendon transfer, you can't repair this.
Yes,
okay. All right. So that's the key point. This was a recent short case in the recent November Part 2 exam. So guys, whenever you see a distal radius fracture, the FRCS, you've got to remember it's a consultant entry exam. They have to think, how can I get this candidate to show higher order thinking? So they're not just going to give you something basic. If they give you a distal radius fracture, they may either want you to look at, oh, maybe that's not as benign as it looks. There might be a bit of shortening. There may be a bit of dorsal comminution. So this is one that could potentially slip. So even if you treat it conservatively, you're going to watch it very carefully, and that might change. Or the other thing to be aware of is always think EPL rupture, because then you won't miss it. You won't miss it. So this is what I tell all my trainees to do, and I used to do myself. I would call it cycling a topic, where I'd look at it and I would just think of the higher order thinking. Where do I think that's going to go? And you're keeping it in your mind all the way going into the exam. Yeah. It's like if I see any child in the exam who has shoulder problems. Okay. Any child in the exam who has shoulder problems, as far as I'm concerned, has an osteochondroma until proven otherwise. Because I've seen it so many times where literally they'll say this child has got weird movements, and then candidate doesn't examine, just looks there, doesn't examine them, and then the examiner will say in the very last minute, can you lift their arm up? There's a huge osteochondroma. So if you don't think about it, you'll miss it. So keep that in the back of your mind so you don't forget it. It's a common trick that they pull in the exam. EPL rupture is very common. Yeah. You don't worry too much about the X-rays. I just literally grabbed one off the internet. I typed in undisplaced distal radius fracture. Now clearly it's not. I agree with Melinda. It's not a perfect position, and in a young person, there possibly is a bit of shortening. There's a radial styloid injury. There is a bit of dorsal comminution. So this is, even if I treat this conservatively, I would watch it like a hawk, because this is one which may slip. Okay, so don't worry too much about that. This is not an actual case. I wanted to focus on this. This was my focus, basically. Okay. Good. So, yes. Young man in the back, sorry. This is a patient who's been playing cricket, standing in the slips, went to catch the ball, and then presented to A&E with this deformity here. And these are the radiographs.
Yeah, radiograph of the lateral radiograph of the finger. I'm not sure entirely which finger that, or I would go for an AP view as well.
Okay.
This view, the most obvious picture is that there is a dorsal UIPJ dislocation.
Very good.
I cannot see any fracture from there. I will need to make sure that this is a closed neurovascular injury. I will reduce that to
How are you going to reduce it?
So with this kind of injury, I would be worried about the polar plate position. So I will probably increase the deformity a little bit more dorsiflexion, accentuate, and then I will reduce it down, and I will put him in a dorsal neuropathy.
Okay. So this is a volar plate injury typically, isn't it? So classically with these, if you reduce them, fine. They're actually, is this a good injury to have or a bad injury if you were going to dislocate your PIP joint? Yeah. So classically with these, you can get them going pretty soon because it's usually a stable injury. Do you find that as well? Would you normally? Yeah. Volar plate injuries. And you can, as you said, you can worsen deformity, give a bit of traction, okay, to reduce it. Is this a good injury or a bad injury?
No, it's associated with a central dislocation.
Yeah, so the volar plate, the volar dislocations are entirely different. This is actually a complex dislocation because it's got a bony involvement. So we say simple if it's a pure dislocation, complex if there's bony involvement. Okay, so this is different and it has a central slip injury. So this one, even if you reduce it, you need to immobilize that for 6 weeks, probably in a cape and a splint, to keep that PIP joint hyperextension. So it's just something to be aware of. Okay. If I give you this patient here, next person, what does this show?
Multiple dislocation, MCP joint dislocation of the ring and the little finger. Looks like it is a fracture dislocation of the
Okay, I think it's probably just a dislocation, but the reason why I put this one up is, so what we say is simple and complex in a PIP joint dislocation means dislocation alone or dislocation with a fracture. Simple or complex in an MCPJ dislocation means what? It's reducible or irreducible. Why might this become irreducible? What's your concern? What becomes interposed? Volar plate. Okay, so I just said to you in a PIP joint one, you can apply traction. What happens if you apply traction with this one? The volar plate will fall into the hole and it will go from being simple to complex and you will have to open up. Okay, so what is your reduction maneuver here? Yeah, or sometimes you can even actually push the bits together and then just basically, if it's gone dorsal, you can give a bit of pressure on the proximal phalanx to push it down. Have you seen many of these, Saurabh?
3 or 4 in the last 7 years.
Three, four last 7
years. If I'm totally honest. Twice we had to open up when I was at Denmark Hill.
Yeah.
Here, it just came reduced closed.
Have you seen many of these? Sorry. No, I was asking. Sorry. No. So I just wanted to put this slide in. I've not seen it. I think I've seen one MCP joint dislocation, but I wanted to put that slide in just to sort of show you about the difference between the two, because it's a common thing they bring in the exam. So you've got to understand about PIP joint dislocation, volar plate injury. PIP joint dorsal dislocation, volar plate injury, volar dislocation, central slip injury. But the one to be aware of is an MCP joint dislocation, where you can get volar plate entrapment. So please, please, please do not apply traction to reduce those. Yeah? Is that fair, guys? Yeah? Yeah, please interrupt. Yeah.
I would prefer a dorsal approach through the tendon.
Midline through the tendon, like
midline through the tendon.
Good. And then
try to go through the capsule, try to push out the volar plate.
So like your fight, midline, done, it's still not reducing. So volar plate has interposed, that's why more push.
So give an incision to the volar plate through the joint.
How will you get to the volar plate? Exactly. So you get a McDonald's or freer elevator, because to push it away.
So always think of think one approach, dorsal, midline. Oh, they can ask you if you do volar, then what's the problem? The volar plate is gone, you should go volar. The nerves and vessels come in the midline, you have to make it vary of those, that's all. Volar plate, have you seen a volar plate in MCP? See it? How it looks?
As a no.
Next time when you're doing your dubitrons, tell your consultant to show you. It's just under the tendon, it's there.
Yeah.
So once you've seen it, your hesitation goes. It's a big bulky structure.
It is. So sometimes I've had patients who have fingers in palm deformity, and Dupuytren's patients, and I always consent them for a volar plate release. Okay. So basically, what you do is, you'll do your Brunners and you'll start taking away some of the tissue, and gradually you can move the tendon to one side once you've freed it, and then you have the volar plate. You can make a little H-shaped release in the volar plate. But you have to be very careful. It's very good, because I had one of those where a Dupuytren's where I consented for a volar plate release, and I ended up making a nick, and I made a nick in the FDP tendon because it was so stuck down and scarred, and I had to then repair the FDP tendon. Luckily, the patient did okay, but now I'm always worried now about this volar plate tendon being stuck down. So you have to be very careful. But yeah,
It's the same as the thumb MCP. It's okay, same as the rest of the.
Same technique. Yeah, I think it's same rounds.
If I have to open, I'll still go dorsal because I'm on rotate. And whatever, the volar plate is the only structure I push it. I have to go volar, radial digital nerve is in a different orientation because it has to travel from the nerve and a vary of those nerves. So I'll never go volar in a thumb if I can avoid it.
And all you're doing is you're just getting a freer elevator or a McDonald's just pushing it back. Yeah, that's all it is. Okay, good. So, next gentleman. Right. So this is a 25-year-old who was punching his friend and sustained this injury. Tell me what you see.
So this is a photograph taken lateral. It sees an extra-articular base of the thumb fracture. You know, there's a weak ligament attached to it because of which fragments stay. It's a stable injury. I would like to make sure.
Did you say it's a stable injury, this one?
It's not stable.
Unstable injury, sorry. Yeah.
Injury.
Yeah.
Yeah.
What would you call this injury, this pattern? What's the sort of... Is this Bennett's? It's intra-articular. It's almost a Y-shaped type fracture, isn't it? Yeah. Okay. So you mentioned about Bennett's and Rolando's. What's the difference between them?
Then it's just a single intra-articular fragment. Rolando's got a Y kind of thing.
Yeah. Rolando, not Ronaldo.
No.
He's the one who's on multi-millions every week. So don't get them mixed up. Yeah. So yeah, so there's three types of fractures that you'll see basically in the thumb, base of the thumb. So you might see an extra-articular one, or you might see intra-articular, which can be either Bennett's or Rolando's. Okay. So as you said, Bennett's is where you typically will just have one fracture line here. This bit here is attached to the beak ligament. Okay, and Rolando's is where it's intra-articular. It's typically a Y-shaped fracture. Now, usually with the intra-articulars, you're almost always going to operate. Okay, sometimes if a Bennett's is completely undisplaced, it's in a good position, you may be able to get away with treating that in a thumb spiker. But all the ones that I seem to have, they all seem to have been displaced. And so the difference for me would be in the type of treatment. If it's a Bennett's, it's just a single fracture line. I should be able to potentially just MUA and K-wire that. Okay, and what they may ask you in the exam is, how would you do that? So I would typically get two people, consultant, registrar, or whoever. The consultant, I would always get to do the reduction, and I'll get my registrar to fire the wires. So I will typically put a, can I demonstrate on you, Saurabh? Is that right? Of course. So imagine Saurabh as the patient. I will learn something. And then, so I would typically put one thumb here, and I'm basically applying some traction there, and then some adduction here. And I'm getting my registrar to fire two wires, a bit of abduction. Okay, then?
Brilliant.
Okay, and I'm getting to fire one wire going from base of metacarpal to trapezium, and the other wire going from first to second. Is that how you do the same thing?
Absolutely.
Yeah, typically 1.6 wires, depending on the size of the patient, I would use. Okay, the important point to a Rolando is because it's intra-articular, it's like a Y, you may need to open up. And you might need to do some sort of T-play. Sometimes if you can get the articular surface really beautifully congruent, you can just go again, you know, maybe a wire across into the second and another wire from base of metacarpal to trapezium. But the ones that I've had to do, I think I've had to open. Have you had to open, or can you do them with wires?
Try and get away with wires.
I try and get away with wires if I can, yeah.
It's easy one.
And you don't want to open if you can, because yeah, it is a nightmare. It is a nightmare.
You get arthritis, you can do trapezium, depending on the.
I think the ones that I've been referred were both referred to me in 19 days, and that's why I had to open up with them. But it's not nice. It's not nice. So then that's where when I was mentioning about to Saurabh earlier is like, well, where does Wagner's come in? Okay, so you can approach these dorsal approach, or you can do a Wagner's approach at the junction of the dorsal and glabellar skin. But often with a Rolando, because that fragment is quite volar, you often have to do the Wagner's approach.
Yes.
Yeah, so that's just something to be aware of in the exam. Okay.
The volar weak ligament and that fragment is the constant fragment. So for dorsal to get reduction is hard. Tendon with tether to the plate. This right shot and I have taken over the plate. And it becomes a bit of a fiddle.
It's a fiddle.
So you get away with K wires, it's better.
It's better, definitely. So that's why, guys, my key learning point to you guys so far, and I think this is quite important post-COVID, is we're seeing a lot of finger digit injuries referred to us after 14 days. They're really tough after like 14 days. They're all stuck, partly healed. you're often having to open up. So that's the one thing you need to be saying to your A&Es, saying to your fracture service at work, is fingers need to be seen quickly. They really do. You know, ideally, if you can get some within a week, better, but definitely after 2 weeks, they become real dogs to do. So is that fair, guys? As I think digits really need to be prioritized, you know, even more. Even like I'm probably more of a shoulder surgeon than a hand surgeon, but I would say, you know, proximal humerus, they're not nice, but I could do one at 3 weeks, okay? But fingers are really tough by that point to deal with, you know, digits. So.
What happens if it heals like, sorry, Rishi, can I interfere?
Yeah, please interfere, yes, yeah.
What happens if it heals like this? Forget about the articular surface. There's not a big step there. Rheumatoid arthritis is very good enough, you know that.
It's fine, it's difficult.
It's fine. Articular surface will heal up nicely. Look into the crystal ball. I can tell you, articular surface will heal. This will also heal. Molar-oblique ligament is intact. Good. So, what is your thumb span? Show to all of us. This is your thumb span. See, guys, if thumb is adducted, it will heal up in this. His thumb span, his or her thumb span is reduced. What's the problem then? So you grab big things and need a thumb span, isn't it? So you can't grab things, bigger things, like a kitchen, opening jaws. You need thumb span for those things, which I'll show you in 2 bedrooms also. That's why you want to have thumb span in 2 bedrooms, and the cord goes to the thumb. Sorry, Rishi.
No, please. It's really important, guys. Interrupt away, because I want you to be clear on this. It's very important. Okay. And they might ask you sometimes, you know, what are the deforming forces? And what I was showing with Mr. Agarwal is basically just about how the reduction maneuver, traction, abducting the thumb, applying pressure at the base. I'm just trying to reverse some of those deforming forces.
Adductor policies are adducted to metacarpal.
Yeah, here.
EPL at the base has caused a bit of proximal migration.
Yeah.
Those 2 deforming forces you are reversing.
So you have to reverse that. So that's the way they'll ask that question in the exam. Okay. Right. Now, we are on a hand and wrist course, but Saurabh wanted me to put this one in because it comes up in every single exam and it's done really poorly. Okay, guys? So you might see this, you might think, oh, easy marks. But actually, what I found is the easy questions in the exam are the ones which are done notoriously badly because you have to be perfect on them. Okay, so I'm just going to run this very quickly for you guys. So if they show you this in the exam, they'll say 5-year-old has fallen from the monkey bars, come to A&E, DGH, 10 o'clock at night. Okay, what do you do? All right, so the first thing you do, describe the radiographs. Show higher order thinking, okay? It's a lateral radiograph of the elbow in a skeletally immature individual, which shows a Gartland 3 extension type supracondylar fracture of the humerus. You could also say the anterior spike, could that be open? It's just something to be aware of, okay? So what am I going to do? Well, clinically, make sure there's no evidence of NAI, but on examination, I want to basically document meticulously the neurovascular status, and you need to be specific about what you would do. So I'll check the peripheral pulse, radial pulse and cap refill time, and brachial pulse. I would also check each of the nerves. So you put it in terms that the child understands. So radial nerve by doing a thumbs up, median nerve by doing an OK sign, ulnar nerve by making a star. Okay, the examiner, if you don't volunteer that, they will get you to volunteer that. Okay, I would also check for compartment syndrome, check that they're nice and soft, and I would check for a pucker sign, which is a sign that the anterior fragment may have puckered through brachialis, and this may not reduce closed. All right, they will almost certainly say to you, it's a pink pulseless hand, 10 o'clock at night, what are you going to do? Okay, so my answer for that for the exam is you've got to think to yourself, how do I get through this question? Nice shallow waters. How do I avoid getting into an argument in the exam? And what you don't want to do is you don't want to be getting on to like SCAGs, you know, the merits of taking a pink pulseless hand in the morning or not. You want to sail past that and get on to lateral or cross K-wires. What's the evidence? Cubitus of errors. That's where you want to be going. So just say to them, you know, no, I would take it in the middle of the night. Okay. My reasoning for it is according to the latest BOST guidelines, a pulseless hand, even if it's perfused, is evidence of impaired vascularity. I would make sure that I speak to vascular surgeons before or have them on standby in case we need to open. All right, so you've covered yourself and you've moved on. So this exam is all about sidestepping the obstacles and getting onto the scoring opportunities. All right, so the next part will move to you're in theatre. So that will get you the 6. The 7 will be you're in theatre, what are you going to do? So 4 steps to reduction. Step 1, apply traction. And when you apply traction, don't just pull as hard as you can, orthopaedic brute strength. I want you to stand there, you and your assistant, and I want you to lean back for 5 minutes. Just watch that clock and don't touch the patient. So literally leaning, both of you. Gentle traction, okay? Make sure the patient's nice and relaxed, all right? And that is to correct the length. The next thing I'm going to do is I'm going to get my radiographer to turn the machine slightly oblique and correct varus valgus, a so-called column view. So step 1, length. Step 2, varus valgus. Step 3, I'm going to flex it up, okay? And then step 4, if there's medial comminution, I'll pronate, lateral comminution, supinate. Now, I know in reality, we don't really do that. We just do this and this until it looks normal. But I'm just giving you words from the AO website. So just say that for the exam, all right? The next thing you're going to do is you're going to basically fix this, all right? So you can go either for a lateral or a cross KY construct. In vivo, there's no difference. In vitro, cadaveric studies have shown that cross KYs are slightly stronger, okay? 2 millimeter KYs. The only thing is, whatever you choose, you've got to use the words or terminology for the exam. So if they're lateral KYs, you've got to say, I would get bicolumnar fixation with divergence of my KYs. If it's cross KYs, you must say, I would make a mini open incision, visualize and protect the ulnar nerve. There is no room. I would not just say for the exam, I would say in real life, there's no room just to basically feel that, you know, without visualizing it. You cannot defend that. Remember my word at the very beginning, what can you defend in a coroner's court? I can defend it if I visualize that nerve and I've protected it. Okay? And you'll never be criticized for, forget this bullshit 1 centimeter incision. You make the incision to, if it's my child, I want a safe operation. All right? I don't care if the incision is 3 centimeters. All right? Scars will heal. I want you not to roger the ulnar nerve, please, if you're looking after my child. Okay? I want you to safely do the operation. That's what I want. Okay? You can make tiny incisions when you're the world expert. You've done 5 million of these. Me as a day 1 consultant, I'm going to make a safe incision in any operation. Okay? That's my priority. Okay? Good. So the next thing to do is medial, sorry, if you do cross KYs, you want to say that you would cross proximal to the fracture site. Okay? And then there's what I call markers of reduction. How do you know you've got a good reduction? So you could compare with the other elbow on the AP, check that Bauman's angle has been restored, but you know, in reality, that's quite difficult to see. So on the lateral, just make sure the anterior humeral line bisects the capitellum. And then this is the other important point, guys, to get the top marks. Always, once you've done that, check an external rotation view and an internal rotation view. Okay, I say this from my own experience as a registrar. I did really nice from the middle of the night, got a beautiful review. Oh, it looks fantastic. And then it displaced. And the consultant was like, did you do that view there? I was like, no, I didn't. So I did all the views, I did that, but I didn't do that view. Okay, so that's taught me, you know, so everything I tell you, I've made these mistakes before. Okay, so you know, with you just giving you these tips so you don't there. And then afterwards, they may give you something down the line. The patient comes back 6 months down the line, they've got a cubitus varus deformity. What do you do now? So most of the time, you're just going to observe it. Observe it, counsel the parents, and they usually resolve. If they don't, and they're symptomatic later on, you might do something like an osteotomy, maybe at skeletal maturity or something like that. Okay? Any questions there, guys? Because that's quite a difficult topic. You know what I mean? So break it into 3 parts. The 6 is the initial management in A&E. The 7 is the steps in theatre. And then the 8 may be the evidence for lateral versus cross K-wiring technique and how do you deal with a salvage situation such as a cubitus varus. I've also seen examiners give you something like the patient's on the table and the pulse disappears when you flex it up. What do you do? So my answer would be, I would take one of the wires out, leave one wire in, try and extend it until the pulse comes back, and then maybe then put the wire back in. If it still doesn't come back, you may need to take the wires both out, and you may even need to explore if you have to. Okay?
There's something similar with everything fine, neurovascular, just on the bucket sign there. Would you take the patient overnight?
The pucker sign.
Yeah.
No. So, I mean, I've had a pucker sign quite a few times, and what you do is really good traction and just milking it for 5 minutes. Milking it, it does come with good. The only reason I take it in the middle of the night. I take them. I mean, do you do that sort of? You don't have to take them in the middle of the night if there's no vascular injury. Oh, so you're saying there's no evidence of neurovascular injury, it's just a pucker sign?
Only pucker sign.
Oh, right, okay, yeah, then you could potentially leave it till the morning. But my own experience is, having done one last year, I left it overnight, pucker sign, and it just became incredibly difficult to reduce. And I had to make medial and lateral open incisions just to do that. Whereas Gartland 3s, when you take them in the middle of the night, they're just a lot easier. But sometimes, logistically, you can't. The theatre may be full or whatever like that. So,
if we do up to 12 o'clock, I'll do it.
yeah, if it's 3 in the morning, then leave it. Exactly. Then it's no point.
As which
Yeah.
is swelling, it's not evidence says doing harm. Swelling makes close reduction difficult.
Yeah.
So that's the problem.
So I had one which it came at like, I think 11 at night, and I left it. And in the morning, it was really difficult I had to open up basically. And so after that, I'd probably do it till about sort of midnight, 1 a.m. And then after that, yeah, fine.
Exactly.
Just leave it.
The problem is next day.
Because the other thing you've got to consider as well is the staff overnight. You know, do you have orthopaedic staff? Do you have safety? All that kind of stuff. Is the anaesthetist happy to anesthetize a young child at night? Some hospitals they're not.
I think the OA says we take it overnight, but in practice this is what happened.
Oh, it was a pucker sign.
Yeah.
No, for vascular injury.
Skin necrosis. Due to my developed skin necrosis. With pucker sign.
I wouldn't do that.
Pucker sign means the bone has come off the
Muscle. Yeah.
Yeah.
So the way that you reduce that is different. You don't just put traction, you have to keep milking. So you literally have to, they're quite firm pressure, just milking. So I would, if I had a pucker sign, actually, if I can, get 3, I've done it with 2 other registrars. So one of us applying traction, counter traction, the third person is just milking constantly. Or if there's 2 of you, one applying counter traction and milking with their other thumb. You know, really good firm pressure. You can, and you actually see the bruising start to resolve. It starts to get better. You know what I mean? But they're not easy. They're not easy at all. The other technique, just a quick tip, guys. One of my spinal colleagues showed me this technique. He from his training, which I thought was a really nice technique. He actually said, "Look, you've got such a nice reduction. You do it at the start, and then you prep up and you lose it, or something like that." So actually, what he did was, before you even prep, he does traction, counter traction, gets a really nice thing, and then basically gets the registrar to essentially prep and drape themselves, put the thing on, prep just the lateral side of it, and then they put lateral wiring. And then what you do is you're holding the arm basically reduced with the lateral wiring, while the nurse then drapes, preps the whole thing, and then you then, so actually, and I use that, it was a much easier thing to do. It actually worked really nicely.
That's if you're practicing yourself, but not for an exam.
Not for the exam. No, but you're not doing anything wrong. I'm not saying you're not putting it in, not sterile. I'm saying they're actually going in and they're prepping the arm completely. So they prep, you know, all you're doing is just holding it, but they're prepping everything. They're putting one wire in. You're still holding it until they, you know, the nurse has prepped, draped everything else, and then you go and scrub. But you've got to wire in. Because we always do that. We reduce it beautifully, and then we go and scrub, and it's gone. You're like, well, why did I put in that, you know, effort and work and stuff like that? So, you know.
Last question.
Yeah.
When you talk about evidence, when you're stating it, let's say against that point,
Yeah.
we always say it in not so, let's say, like confirmed terminology, like quote the paper. Or is it better to say it if you know the paper, or can you just say studies have shown that you know, crosswise are better than
If they ask you specifically, I mean, you do not need to quote evidence, guys, to pass this exam. So, but if you do say something, then they may be prepared that they may ask you about that paper.
What would you advise people to stay away from it, not to say that at all, or say that studies have shown that crosswise is better than that, but I can't quote any papers that
I would stay away from it unless they specifically asked. So if they said, you know, the difference between the two, I would say studies have shown that in vivo, there's no difference, but in vitro or cadaveric studies, it's biomechanically stronger. Can you, which study is that? I can't name the exact paper at the moment. Move on. Don't get stuttery. If the examiner pushes you, they've asked me, they've like, I stupidly said Parvise's criteria for MSIS infection. He's like, can you name Parvise's criteria? And I screwed myself. And I just said, look, I'm so sorry. I've drawn a blank. I can't remember at this moment. Move on. Score other marks. Yeah. It's all about sidestepping. You know, don't let the great white sharks into the cage. Do you know what I mean? So,
How frequently would they go to a cubitus varus? Is it a common question?
Usually, if you are doing very well, I've seen the mark scheme, they will go to some sort of salvage scenario, but most people don't get that far because they waste time. So the other thing I've seen asked is, actually, I think, yeah, so one thing I've seen asked here is, so that's the standard, what I was saying, divergent for lateral K-wires. You can see here that the anterior humeral line bisects the capitellum. Oh, no, I didn't put the X-ray in. Ah, okay, sorry. I had an X-ray of one that had displaced with a cross K-wire, and it's because the wires were crossing at the fracture site. So I was going to get you to critique that X-ray. Sorry, but it's just to say that, yeah, so lateral K-wires, in terms of divergence, I have seen the AO website, and the way that they quote it is they say at the fracture site, the distance between the wires should be more than a third the distance across the fracture. That's what the AO website says. That's how much divergence you want. Does that make sense, guys? So if I look at that horizontal line where the fracture is, that distance there.
I'm going to draw some lines for them.
Oh.
Show me the K-wire, how we put it.
Oh, okay, yeah, very nice, very nice. Yeah, good one.
You can't escape.
Rishi,
Yes, hit it.
Rishi, can I take a question from the audience?
Yes, please, guys. Yes, please ask me an audience question.
Okay. One Dr. Ignatius Liu has asked a question. If I am in a district general hospital with no vascular surgeon backup, do I say in the exam to transfer? That means to transfer to where a place where microvascular or plastics are there.
In the exam, yes, or at least, so you would discuss it with vascular, but ideally, if there's a potential that it's a vascular injury, you should transfer it, or you should at least say that you discuss it with them first. If they say, look, the transfer is going to be delayed and there will be an unnecessary delay, then you would say, fine, the thing which is going to relieve the pressure on the vessel is by reducing it. And my answer for the exam would be discuss it with the vascular team first, and if there's no vascular team on standby, transfer it to one which does have it. If there is a vascular injury, if there's pulselessness.
That's only if there is a suspicion of a vascular injury, right?
Absolutely. So if this is a pink pulseless hand.
Okay. Thank you. You can continue, Rishi.
Okay, so I think that's the end of my talk, guys. I was going to go on to Saurav next, but I think Saurav wanted to test the guys here about wire placement.
Just a little something came to my mind.
Yes, tell me.
Hitesh, give me 5 or 7 minutes and we'll be back on your live.
Okay, Saurabh.
Yeah, so just pause for about 5 to 10 minutes, yeah? Great.
Brilliant. Check out the lights.
Yeah.